me? Hello?
Hello, we can hear you
No, we
now.
lost you at some point here.
Okay, we cannot hear him.
Oh, right. So let's pray. Father, to
Okay.
bring us together. Hello, can you hear me now?
The line is breaking, sir. But we can
Hello?
hear you now. I can hear you now.
Okay. So we are
Please
praying.
just go ahead and yeah.
Okay. Heavenly Father, we thank you for tonight, and we thank you for the opportunity to bring us together as professionals. We commit our meeting tonight into your hands, and we ask you to take absolute control. Let us have a successful deliberation that will lead to learning and application of this knowledge. We thank you for answered prayer in Jesus' name. Amen.
Amen. Thank you very
Amen.
much, sir.
Amen.
Good evening once again. Please, can we mute our mic? Good evening once again, everyone. On behalf of CPAN National, oh God. Okay. On behalf of CPAN National and the Critical Care Pharmacists of Nigeria, I warmly welcome you to tonight's very educational session. My name is Isila Melinda, and I will be serving as the moderator for this presentation. We kindly ask that you give us your full attention throughout the session, and you're welcome to note your questions, which will be addressed at the end of the presentation. It's a pleasure to have you all join us for this very important topic themed When Seconds Count, the critical role of the ICU team in saving lives. This presentation will focus on the importance of the ICU team in delivering timely, life-saving care, the value of effective teamwork in critical care settings, the essential role that critical care pharmacists play, and how rapid interdisciplinary collaboration can significantly improve patients' outcome. Without further ado, I would like to introduce our first presenter. She's from Adasa Mwese Babalola, BFAM, MSc FAM, MSc Clinical Pharmacy, FPC FAM, Critical Care and Specialized Nutrition Support, Critical Care Pharmacy Certificates from the UCLH UK, Desk Officer 1, Critical Care Pharmacist of Nigeria, and Assistant Director of Pharmaceutical Service at the Lagos University Teaching Hospital. Ma, you can have the floor.
All right, thank you so much. Yeah, Linda, for excellent moderation. So I'll be talking on the topic. Let me try and share my screen. And just hold on, I'm trying to share my screen and make it large enough for everyone to see.
Okay, ma.
Can you see my screen? Can you see my screen?
Yes, ma, we can.
Okay, so you have introduced the topic. I want to thank everyone for taking out time at this time. At this time of the day to be here. That means this really means a lot to you. And so I'll be taking you through the title, just like I said, When Seconds Count, the critical role of the ICU team. So these are my contents. I'm going to have an introduction, then try to get us to understand the environment, why seconds matter in critical care, the multidisciplinary team, the power of communication. Then I'll give a typical second count scenario. how technology can support the ICU, the challenges we have working in the ICU, and lessons we can learn, conclusion and my references. So that's what I'm going to have to take us through this evening. Can you all hear me?
Yes, ma'am.
Sorry, is it only Linda that can hear me? Hello, can someone else talk? So I'm sure everybody's hearing me, please. Kwame, are you there? Hello? Hello, can someone else talk to?
Yes, can we continue? They are muted. If you are muted, there'll be noise.
Oh, okay.
Just continue. They are
Dr.
muted.
Bello, thank you. Thank you for taking out time to be on this call with us. By introduction, we know that a lot of us that are here, I believe, work in the critical care unit, or you have an idea of what it means to work in the critical care, or you're here to learn how critical care works. Now, in the critical care unit, everything like the topic, everything, it's about timing. And how you handle time will determine how quickly you save the life of the patient you're working on. Now, this place is a dynamic place. The environment is quite demanding. You have patients who are at the edge of physiological collapse that require immediate recognition of what is happening. Now, it's very important that when a patient comes into the intensive care unit, diagnosis is key and it should be done quickly too. Now, when that is done, you are able to help save the life of the patient, halt or delay the processes that the person would have gone, ending in death. So recognition of what is happening to the patient and then rapid intervention of what you have discovered that is happening to the patient. And then not just that, diagnosis is key, very important, and it should be done quickly too. In rapid intervention. And then apart from that, you don't leave it at when you have recognized or you have intervened, but there's continuous monitoring of these patients to ensure that they don't deteriorate. So whatever condition you're handling, whatever it is, whether you're managing septic shock, whether respiratory failure, whatever it is, every second counts, just like the topic has put it across. Now, the difference between life and death in the ICU is often determined by how quickly, that's what we're talking about, you discover how quickly the patient is deteriorating and that you're able to communicate. And you will notice as we go on that the unit does not just depend on one person. And it's very important that there's communication among the team members, and it is understood clearly that each person understands what the person is communicating enough to be able to help the patient, and then initiates treatment promptly, and then reassess your outcome each point in time. Now, I said, it is not something in isolation. It is a group of people coming together to save, in fact, just a life in the unit. Now, how do we understand this environment? Now, it is a specialized environment. In managing critical care units, it is a really specialized environment. And it's a clarion call as make this presentation that we would have people join us. If you'll notice, even in the fellowship, once in a while we have just one person specializing. And so we have people working in the critical units that are not trained, and working in the critical units should be that are trained and are specialties in this particular unit, because there's a whole lot happening that would need people that are specialized to handle the issues. Now, in this environment, we have advanced technologies. We have things like mechanical ventilation. You have to understand, the person handling the patient has to understand whether mechanical ventilation that should this patient, should it be invasive or non-invasive. It's quite important to be able to identify as you want to mechanically ventilate the patient. Is it an invasive procedure you want to carry out on this patient or non-invasive? Now, hemodynamic monitoring, very important. Now, most of the time when we hear about hemodynamic monitoring, what comes to our mind? Oh, blood pressure. Yes, so in the intensive care unit, there are a number of factors we're looking at when we're talking about hemodynamic monitoring. You have to ensure that cardiac output is optimized, excellent oxygen delivery, for there to be adequate tissue perfusion. And the ultimate of everything you're trying to do at the end of the day is to ensure that there's excellent, adequate tissue perfusion. So you're looking at the cardiac output, is it adequate? You're looking at the oxygen delivery, is it delivering enough adequately to where it should be at the tissues? You're also looking at the pressure. Now, all these factors are supposed to be carried out together. So you can have the pressure. You can be looking at the pressure is normal. Then tissue perfusion is not adequate. So you're looking at all the parameters together. You're monitoring and ensuring that at least the parameters are going hand in hand. Not one is adequate, but then the other, at the other end, we're not having enough tissue perfusion. There's renal replacement therapies, there's advanced pharmacotherapy, there's continuous neurological monitoring. It's very important. In neurological monitoring, if it is not done adequately, and if you are not top of your game, you discover that the patient is losing a lot of neurons at each point in time. Assessing the patient here, your what do you call this now? You're using intracranial pressure to measure out that, ensuring that is within the range. It shouldn't be up more than 15, with millimeter mercury, and also other parameters to ensure that the patient is not losing in neurological neurons, not losing that. And then other advanced technologies. So unlike other hospital units, the ICU care is dynamic and minute to minute. You're monitoring the patient holistically. You have gadgets that help you monitor these patients, and you're ensuring that they're working optimally so that you're getting the right result at each point in time. Because if that is not done, patients will deteriorate in seconds, and that will result into working futility, having worked for the whole day, and then there's no adequate monitoring to ensure that the patient is good. So why it matters, why secondary the critical care, any ICU emergencies are time sensitive, whether it is septic shock, your delay in antibiotic administrations beyond 1 hour significantly increases mortality. And also cardiac arrest, these are the things the patient is going through, cardiac arrest, each minute, CPR. This evening, before I left to work, somebody actually got to the red line, and that is where they actually stopped to do it. They were actually bringing and doing the CPR the life of this patient. So whether it is acute respiratory failure, delay in airway management can rapidly lead to hypoxia and actually leads to brain injury. Now, and neurological emergencies, time is brain. Every minute that it is left untreated, it means neuronal loss, just like I had said before. And so, now the ICU team, one person cannot do it all. So you have a group of people working together, and that is why we call it a specialized unit. And each person in the ICU that forms part of the team, specialized, is a specialist in what they have brought to the team. So we have a number of members in the team and actually work together as a team. And even when we have ward rounds, we're ensuring that every member of the team is represented. Member left out, there definitely is going to be an issue. So one of the people we have is, of course, definitely the intensivist and also critical care physicians. So there are specialized doctors that are intensivists handling the intensive care patients. Now, there are other critical care physicians just working along with them to ensure that everything is fine. And what are their roles? The roles of the intensive care intensivists are to ensure that there's rapid diagnosis of whatever the condition is. Like I said, if it is not correctly the right time, then it's working futility. You don't want to do a wrong diagnosis and after going to a certain extent, you now, oh no, it is not right. Time is very important and you will lose that patient before you know what is happening. So it is very important. These ones are trained to be able to do diagnosis quickly, fast, and to ensure that everything is communicated. Oh, this is what we have found. And you're able to communicate to the other team members that, look, this is what we're dealing with. And everybody's prepared for this patient. So apart from rapid diagnosis, there's dynamic optimization. They're able to, look at the physiology of the patient, look at what is happening at the patient at that time, and try to match each of these things to ensure that treatment that is coming is right, and all that, and also to escalate to advanced support. They're also the ones that are communicating with the family members and telling them the prognosis of the patient. They're talking to the family members and letting them know how far and how good the patient is going or how bad it is to prepare their minds for whatever comes out by the end of the day. So the ICU nurses are actually the frontline guardians. They are actually the first to dictate where the patient is deteriorating because they are the ones sitting with the patients right in the unit. And there's continuous bed monitoring, early warning recognition of any deterioration. There's medication administration, ventilator care. And in many cases, nurses save lives simply by noticing that something early. Now, if a nurse sits there and is carried away, they may, within split seconds, something can go wrong. And I mean, something that should have been prevented goes wrong because the patient, the nurse is not paying attention. In fact, for me, if you see what the nurses do, if we're going to pay according to the workload done, then these ones should be paid because most of the time they're really just sitting and monitoring. They really want to do the work and they're monitoring very well to ensure that the patients do not deteriorate and go very bad. So they're very important members of the team and they're very valuable members of the team too. So we have the critical care pharmacists and also, so like I was making a clear call. We have just few certified critical care pharmacists. And by this meeting, I'm hoping that we would have been able to talk enough, be able to get more people, join in this specialty. So we have clinical pharmacists that can also play a major role in helping in the role of pharmacists in the critical care unit. Now, the major responsibility of critical care pharmacists in this unit is to optimize pharmacotherapy. Now, the roles include inotrope and vasopressor titration. It's very important that the pharmacist is able to calculate, especially the infusion rate, what the inotropes or vasopressors that the patient is on. Should be able to look at the patient and say, okay, this is adequate or this is not adequate. Your infusion rate formula is quite simple. It's in microgram kg per minute, multiplied with weight times time, all divided by the concentration of the drug. So with that, you are able to help the team to ensure that there's adequate titration of inotropes or vasopressors that a patient is on. And drug compatibility checks, very important too. You're able to, because the patient is taking a number of drugs. The patient is taking a number of drugs, and you want to ensure that all drugs are compatible. We had a case of where a patient, I think a patient had a number of antibiotics. Normally we have antimicrobial stewardship ward round on it. So apart from the general ward round that we have with the team, we have antimicrobial steward antimicrobial stewardship ward round 2, where we have the different specialties coming. You have the intensivist, you have the infectious disease microbiologists, the pharmacists are there too, and all that. And on this we had a case where we had a patient on a number of antibiotics, tigecycline and tyrosine B, and there is incompatibility where these two come in contact. There's a tendency to be precipitates are formed and all that. So we had to try to advise on how the nurses would administer so that there would not be any form of reaction that is not needed, and all that will cause harm to the patient. So in the midst of giving the number of drugs you're giving, because each drug is meant for a particular thing, there's a possibility that there may be incompatibilities. And it's the duty of the pharmacist to check out this and ensure, are we giving these a few minutes before they are, or is it not supposed to be even given, or should we give this some minutes or hours before this other one? That's important to note. Then in renal hepatic dosing, so the pharmacist comes in there to ensure, because of course we know that there are major the organs are not working optimally anymore, and then you are ensuring that the doses you are able to know that, okay, this is how much of the organ is optimal, and so you're able to reduce the dose in such a way that there is no toxicity to the patient or overdosing to the patient. And antimicrobial stewardship, there's a whole lot going on. The antimicrobial stewardship, just like we said earlier, it's important that the antibiotics are given, especially when in septic shock. In septic shock, you want to ensure that the antimicrobial given to the patients is done timely, and adequate too. So you are ensuring that the right molecule is chosen at each point in time, and then there is no interaction between these molecules. So I think this week, antimicrobial stewardship, we had cefepime given with amoxiclav. Of course, the prescription, I think, was written by the intensivists. And so I flagged it up them and said, they explained to me, oh, so we have this person with sepsis and the person has pneumonia too. And so we're thinking of it, or we're thinking of the two drugs to sort out the different issues. But I looked at it that it was therapeutic duplication in that case. So I reached out to the infectious disease doctor, which agreed with me that, oh, no, we should do one and not two. So it's complicated. And cefepime was dropped for a month plan. And that's fed out the matter for that case. So monitoring in this case too, like when you start, it is very important to be able to start time to administer the antimicrobial molecule that you want to give to the patient, and then it should be done time too. And when there's a need, you have to ensure that drugs that are given at the antimicrobials that are given at each time are the ones that the patient need and interaction or overlapping therapeutic duplication or any of such. And they should also, the pharmacists also looking at prevention of adverse events. There's a whole lot that the patient is having. In fact, there's a reason why we use the FAST MEDINS acronym to be able to sort out the patient. And in the midst of that, that doesn't prevent adverse drugs events from coming up. So the critical care pharmacist is watching closely to see that, oh, nothing is, none of the molecules to the patient is adversely affecting the patient. Now, medication reconciliation is another very, very important thing that we neglect most of the time. This should be done when the patient comes into the unit. While the patient is inside the unit, it's something that should be done, every day. Or in fact, let me not say every day, let me say at each point in time to ensure that the different specialties, the different teams coming in are not giving something at the end of the day is affecting whether drug interaction, whether drug disease interaction. whether drug-food interaction. So it's the duty of the pharmacist to ensure that while the patient is in the report, right in the ward, they're monitoring closely to see that whatever drug the patient is taking is what the patient should take at each time. That's it. Interaction. There can be drug-disease interaction. A very important one that we met sometime was this a big molecule that the doctors were. Are you hearing me? Am I just talking to myself? It's so quiet that I expect I want somebody to say something.
We can hear you, ma'am.
We can
Oh,
Yeah,
hear
we can
you.
hear
We
you.
can hear you.
Okay.
We
We
can
can
hear
hear
you
you,
clearly.
Okay, that's fine. All right. So this molecule for gout, for Bosostat, came into the market, and you know how normally the reps come in with new molecule and we wanted to try it and all that. But then we know that most patients in the ICU would come down with cardiovascular issues, and it's contraindicated in patients that have such issues. So we had this patient come in. It was in the course of medication reconciliation that we discovered that, oh, this person shouldn't be on Febuxostat, and that we were able to communicate the doctors. And then that was handled. Then we had another issue where we were on ward rounds, and then we had patient was given cetirizine, calcium gluconate, and the patient started desaturating quickly. So it looked like the patient that was doing well, all of a sudden started desaturating. So that gave us, and we quickly checked to discover that, okay, cetirizine together with any calcium molecule, because we got it that there will be precipitation between, there's a chelation between the cetirizine and the calcium, and then cause precipitates that by the end of the day, the proceeds were the of the patients to breathe. So that's too. So medication reconciliation can never be underestimated. It is, you do it when the patient comes into the unit, to know the drug the patient is coming in with. You do it when the patient is in the unit, and continuous monitoring, because you will discover most specialties are coming in on what the patient has coming in. You can have the allergy doctors coming, you can have the urologist doctors coming, you can have the respiratory doctors coming, you have different people coming at different points in time. The duty of the pharmacist to ensure they're trying to reconcile what they have done, to ensure medication reconciliation, it's still what the patient should have. It is our job as this end of the units to ensure that whatever patient is taking, that is help, that's giving good therapeutic outcomes and not harm. Like I always say that for us, there's no manufacturer that makes any drug with the hope that it should cause any harm. Each manufacturer is making a drug molecule, and what they want it to do is that the patient benefits from it. So my own duty is to ensure that which was in the mind of the creator or the manufacturer of that drug comes to effect and the patient benefits from it. So in emergencies, the pharmacist ensure that the right drug reaches the right patient in the right dose and all immediately it is prescribed. So we have another group of people, the respiratory therapists. These are the ones that handle the airway and ventilator management. Now they manage the mechanical ventilation, they troubleshoot ventilators, ensure that the tubes that are not displaced, and if there's factors to ensure that they're ensuring that the tubes are not displaced, they're ensuring that tubes are not obstructed, because as soon as that happens, the ventilator is beeping sometimes. And so they're ensuring that everything is fine, as the patient is ventilated. They assist in intubation. And generally, they ensure that the reason why the patients are there for mechanical ventilation, and critical care support. So that part of the mechanical ventilation, the respiratory therapists are ensuring that the patient is getting the best part of ventilation. And the others are lab and diagnostic teams. These ones also they when I see ABG, it reminds me, you know, a very good technology that helps you is it's at a sports kind of um test side, just then the blood sample is taken, patient, and then a lot of things are gotten. The hemodynamic parameters of the patient are gotten in a few minutes. They're also lactate. You're ensuring that the lactate, that's one thing that tells you whether there's enough tissue patient or it's not. Ensuring that lactate is equal to 65 millimeter mercury. The electrolytes are within limits. Controls that are taken are brought back. They're able to interpret and tell us, oh, this is what at this time. This is the mechanism it said this is happening to the the patients and all that. And that is communicated to the team members and taken up and the patient is treated as needed. They do cardiac too. The next group is the radiology team. We know they're responsible for imaging and urgent diagnosis. So CT plus stroke trauma, chest X-rays, and ultrasound guidance. Physiotherapists are they're very important, very important members of the team, because when they come in time, they're able to reduce most of these ICU acquired weaknesses. The patient is not mobile, is not moving, it's just stationary. And so they're helping to ensure we come in and begin to take the patient with physiotherapy, ensure that all those weaknesses that come as a result of the patient not using their limbs in a long time, are ruled out most of the time.
Hello, Ma, you're taking time. Oh, hello.
So what should I do?
You're taking time.
What should I do?
I said maybe you should try to round up.
And let me try and round up. I'm on slide. I don't know whether this is the last slide. You should have allowed me to just land. So they reduce the length of stay too. The dietitians are there to improve improves output and healing. So the support staff and porters are very important. Moving up patients, or moving up the patients to city or theater, having how survival rate of the patients. So the power of communication, very important, that has been mentioned. Communication between the team is very key. Getting it right, getting the right thing that you're communicating with, you're saying is very important. This evening we had somebody went to the pharmacy and say, oh, I want no adrenaline. The question was, are you sure it's not adrenaline? And she says, yes, it's not adrenaline. You're trying to resuscitate a patient. He said, no adrenaline, you want adrenaline. She said, no adrenaline. Give no adrenaline. She ran back. It is adrenaline. So it's very important that communication to the right place well, and it's communicated rightly, and they also are able to do the right thing to be able to say patient. More communication remains the key thing that disturbs issues in us. So a typical second count scenario, patient becomes hypertensive, for example, within seconds, the nurses will notice that there's a falling BP, the alarm sounds, the physician assess bedside, pharmacists prepare and adjust drugs, and then the lab people are there with urgent at ABG, the team activates and responds. Technology support, efficient comms, electronic health records, that go a long way to help in taking care of the patient. But it will never replace the healthcare team. Now, the challenges we face in the ICU team, in the team is the burnout, shortages, communication, emotional burnout, and resource limitations. Now, building high-performance ICU team is very important. Now, their trainings, interprofessional education, clear road definition, psychological safety, the preparing after emergencies, and leadership development. Strong ICU culture saves more lives. Lessons from that I won't take in conclusions. 1 second counts, no single clinician saves life alone. It is the nurse who detects the deterioration, physician who directs action, it is the pharmacist who prepares the therapy, it is the respiratory therapist who secures breathing, It is the laboratory people carry out those tests and send the data to the ICU team. It's working as one saves life. The ICU is not simply a place filled with machines. It is a place where team and urgency into adding urgency into saving the life of patients, caring and moving seconds. And seconds into circumstances that the patient is it's by the end of the day. The joy of working in the intensive care unit is having someone that looks like death coming back to appreciate the team. Pause after he was restored and come back to appreciate the team. Thank you all for listening. These are my references, and God bless you. Thanks for listening.
Thank you, Ma, for that comprehensive presentation and the clinical insights that you shared, especially on why timely intervention determines the difference between life and death, and also detailing the role of critical care pharmacists. I am pleased to invite our next speaker, Dr. Ogero Gene Agogo Timipri, BPharm, PharmD, MSc Clinical Pharmacy, FPC Pharm, Critical Care and Specialized Nutrition Support, Critical Care Pharmacy Certificate from UCLH UK, SCPAN Desk Officer 2, CCPON, CPAN National Publicity Secretary, and Assistant Director of Pharmacy, Federal Medical Center, Yenagwa. Ma?
Thank you very much. Thank you very much, Pharmacist Linda. Thank you, our first presenter, this Officer 1, for that very enlightening presentation. So I'm just going to rush to my presentation. Dr. Bello, please, can you please make me, so that I can share my slides? And Dr. Pharmacist Babalola, please, can you stop sharing so I can share my slides? So I'm going to be discussing the same, almost run through what have been discussed. But first of all, I want to sincerely appreciate the organizers of the National Critical Care Awareness and Recognition Month 2026 and Critical Care Pharmacists of Nigeria for this opportunity to speak today. This presentation, when seconds counts, the critical role of the ICU team in saving life is very, very important. Please, Ma, can you stop sharing so I can share my slides? I'm waiting. So, like I did mention, this month of May is a National Critical Care Awareness and Recognition Month. And so, what we do this month of May, we take the awareness seriously from May 1st to May 31st. So we know that critical care medicine, it's one of the most demanding and time-sensitive areas in the healthcare. This is because rapid decision and teamwork can determine if a patient is going to survive or if a patient is going to deteriorate. So we are going to be discussing the importance of multidisciplinary collaboration in the ICU and how every member of that healthcare team contributes to improving the life of the patient. So as we know, the ICU patients are critically ill and they require constant monitoring, and there's also rapid assessment, and there must be an immediate intervention. So in the ICU, conditions can deteriorate within seconds, minutes, and any delay in the treatment, just like my desk officer 1 already mentioned, can lead to severe complication, and even most times the patient can even die. That is why critical care depends heavily on a teamwork. There must be communication, there must be decision making. So the ICU also is not sustained by one person alone. It is a teamwork and it's made up of, she already mentioned the ICU team, and she even tried to explain each member of the team. So, but what is critical care? Before discussing the ICU team further, I would like us to briefly look at what critical care really involves. Critical care actually involves management of patients with life-threatening but potentially reversible conditions. These patients can require specialized monitoring or advanced supportive care. That's when you go to the intensive care unit, you see sophisticated, equipment, and that's another way again you need to learn how to use them. We have some severe examples like severe infections, respiratory failure, stroke, trauma, even cardiac emergencies, because this condition can change rapidly. So ICU management requires continuous assessment, reassessment, and prompt intervention. So that's why the seconds matters. Seconds matters a lot. Then in critical care, timing is extremely important, because if there is delay in antibiotics, for instance, when it comes to septic shock, that could really be a problem. When there is delayed intervention in stroke, it can lead to brain injury, and this brain injury can be irreversible. Or if there's any delayed correction of arrhythmia, can significantly worsen patients' outcome. That is why rapid recognition and coordinated response are essential in ICU care. And in critical care, timing is extremely, very, very important. Now, I want to talk about the ICU team structure. I won't talk so much because Fam Babalola already talked about it, but this is what the structure looks like. It's a multidisciplinary unit. The intensivist, who is a physician, then the nurses will be there. Then where we are really concerned, the critical care pharmacists, I have to put it in blue to emphasize that. And then we have the respiratory, we have the lab scientists and the radiology team and the nutrition support team. These ones are very, very important, because sometimes when the patient comes in, patient is deteriorated, weak, malnutrition plays a lot of role. And we have the dietitians who work in collaboration with others to make sure that they get the accurate feed that they can take. There are lots of moving into parenteral nutrition specialized for them. And so it's very, very important. So in essence, each member contributes specialized knowledge towards patient stabilization and patient's recovery. Then what then is a critical pharmacist role in ICE? There is an area particularly important for us. She already mentioned it. We have the medication optimization, antimicrobial stewardship. There's always temptation, actually, because sometimes this patient comes in a coma, and they attempt to begin to start with high-level antibiotics. So there is need for those adjustments, because sometimes there's organ dysfunction, monitoring drug interaction and adverse effects, and prevention of medication errors. Pharmacists also participate actively during ICU ward, and they contribute to any decision that is made there, evidence-based decision making. So our intervention can help to improve medication safety and also patients' outcome. Now, from my slide 7 to 9, I have case scenarios of different disease conditions. Here we have examples of how multidisciplinary collaboration becomes necessary in real clinical situation, like this first case talking about sepsis. Here is a common example of critically ill patient presenting with severe infection that is progressing towards septic shock. In this case, this patient may initially present with maybe fever, hypotension, tachycardia, altered mental, status, also worsening organ function. But in sepsis management, time is extremely important, because delayed intervention can rapidly lead to multi-organ failure and then death. At this stage, the ICU team must act quickly. They must recognize early. Then there must be prompt antibiotic administration. Then also fluid resuscitation. And then there must be close monitoring and vasopressor support where necessary. And so the critical care pharmacist plays a major role in all this. What does he or she do? Appropriate antibiotic selection. There must be correct dosing. There must be prevention of drug interaction and antibiotic stewardship. This case highlights how rapid multidisciplinary intervention improves patient safety. Then for case 2, a patient that has cardiac condition. This scenario involves a patient with acute heart failure or maybe a life-threatening arrhythmia that is admitted into the ICU. This patient may have presented with chest pain, started with shortness of breath, unstable blood pressure, hemodynamics may not be stable, or any recurrent arrhythmia. Management often requires a continuous cardiac monitoring. There could be oxygen support, electrolyte correction, and infusion therapy is very, very important. And also, because of the they must add anti-arrhythmia like the vasopressor. So abnormalities in potassium, magnesium level can even worsen. Electrolytes may begin to, fluctuate and increase the risk of cardiac arrest. What does the ICU pharmacist do in that case? The ICU pharmacist plays a major role in reviewing medication therapy, monitoring drug safety, adjusting doses, and ensuring appropriate administration of high-risk medication. Then this also demonstrates the importance of precision, teamwork, and timely intervention in critical care. Then I want to talk briefly on neuro ICU, but this is very, very common, and it's becoming really common in the world. Now, this case now represents a patient in the neurocritical care unit, such as maybe there's a post-stroke or post-neurosurgical patient. These patients are highly vulnerable and requires close neurological monitoring because deterioration can occur suddenly. So some common concerns could include raised intracranial pressure, and then they may decide to give some infusions like mannitol. Then the patient can also have seizures, infections, and there could be thromboembolic complications and medication-related adverse effects. Now, the management involves coordinated care among physicians, nurses, pharmacists, and even other ICU team members that we've also mentioned before. But what does the pharmacy do in this case? The pharmacist will make sure that it optimizes anticoagulation therapy. They must monitor antimicrobial use, preventing medication error, and ensuring safe medication administration in neurological unstable patients. So this scene again further emphasizes that successful ICU management depends on effective multidisciplinary collaboration. So our emphasis is that it is a multidisciplinary use. No one healthcare professional can do this job. It's not possible. So she talked about communication in ICU. It is very, very important, especially when it comes to ICU safe ICU practice. There's structured handovers, timely updates, multidisciplinary discussion can help to reduce errors and also improve coordination of care. When there is poor communication, critical care have serious consequences. So it is very, very important that everybody in that team must be open-minded to communication. Now, the challenges she also mentioned, some of the challenges we have in ICU, despite advances in critical care practices, there are several challenges. Drug shortages. Just imagine that a patient is in a very critical condition and they are attending to the patient and suddenly a drug is needed and there is none. There is also limited staffing. There's delayed patient presentation. Patients don't come early and all that. They come when the conditions is already critical. And there's increased complexity of critical ill patient. So these challenges can emphasize the importance of teamwork. When there is good teamwork, then we can be sure that patients will be to save life. Then impact of teamwork, when healthcare professionals collaborate effectively, patients' outcome improves significantly because there is reduced mortality, there is reduced medication error, there's shortened ICU stay. And then also ICU success is truly a team achievement because it helps to improve the overall quality of care. So how does a day in the ICU look like? Well, this slide gives us a brief picture of what daily activities in the ICU look like, because the ICU environment is fast-paced, demanding, constantly active, because critically ill patient requires continuous attention and monitoring. So a typical care day often starts with multidisciplinary ward round, where the healthcare team review each patient's condition, they look at the lab investigation, medication, nutrition plan, and the overall progress of the patient. Throughout that day, the healthcare professional responds to emergencies, they adjust the treatment, they monitor vital signs, they review medication, and make rapid clinical decisions based on change in patient's condition. Now, the pharmacist contributes by also helping to review medication therapy, identify potential drug-related problems, and also optimize dosing. And the pharmacist also ensures that the medication is safe, affordable, and it is easily accessible. Then the nurses, we know that the nurses, they provide continuous bedside monitoring and immediate patient care, while the physicians, they coordinate overall clinical management. Even during the night, you heard when pharmacist Abayola mentioned that just a case, she had a case before she closed today. ICU care continues because patients' condition can change suddenly at any time. So even in the night is not a time to even rest. Patients are monitored all through. So this highlights the intense level of teamwork, communication, vigilance is very, very important, and dedication required in critical care practice every single day. So what is the call to action? The call to action is that we as pharmacists or pharmacists that are interested in critical care or pharmacists that are already in critical care, we want to continue to improve ourselves. We want to support critical care training. Now, the Society of Critical Care Medicine, SCCM, they partnered with the American Association of Critical Care Nurses, American College of Chest Physicians, American Thoracic Society, and American Association of Respiratory Care, in collaboration with this National Critical Care Awareness and Recognition Month, to mark this month of May, to recognize the critical care colleagues and raise awareness of their valuable work. So that was what we did in CPAN, and we did in clinical care, critical care pharmacists of Nigeria began to raise awareness that all critical care pharmacists should turn their ICU blue. And on the 15th of May, 2026, that's last week Friday, they wore blue. It is a day for Critical Care Awareness Month, when they recognize those who work in the intensive care units. The nurses celebrated, the physicians celebrated, the pharmacists celebrated. So May actually is the National Critical Care Awareness and Recognition Month. It is. So what we do that period is to promote awareness and educate people who feel that, who don't know much about it. So it's a Wear Blue moment. It's a Wear Blue moment, and it's what we did during that month, just to recognize and appreciate people who have been doing that. So in conclusion, the key take-home message is that in critical care is a fast-paced and high-risk area where every second matters. Successful ICU care depends on effective teamwork. There must be communication and timely intervention. Every single member in that team of ICU play a very important role in improving patient care. So when we find it difficult, when some facilities say pharmacists will not enter the ward, pharmacists will not be there, but they come behind again to see how they can get medication and begin to ask questions, but they don't want you in the ward. They are the ones that are making things hard for themselves. So in conclusion, when second counts, teamwork saves life. So these are my references. Thank you so much.
Thank you, Ma, for that very educative presentation. I particularly enjoyed the insights you shared and the practical perspectives that you shared on multidisciplinary critical care management. Now we would open the floor for contributions and questions. I'm sure that we have some questions to ask both our presenters tonight. So I'd like for us to use our raise hand icon, and then we can take turns in giving contributions and also asking questions. So I only see one hand raised. I want to believe that there are more questions. There are more people with questions than just one person. So please, if you have questions, you can raise your hand. So we'll start with Mr. Kwame.
Thank you very much. I think you are still calling me Mr. Kwame.
I'm so
If you
sorry.
want it that way, that's okay. Yes, very, very interesting, insightful presentations. As you are aware, I am from Ghana, but I'm very, very impressed, with what is happening in critical care services or critical care, management in Nigeria. Very, very, very impressive. I'm quite surprised though, how you have come this way, because I heard some time ago, I saw some publications about, some very serious fights between the doctors, pharmacists, discouraging them from even getting involved with training of pharmacists or getting pharmacists to get into some of these spaces. So I'm quite curious to find out how you came here. But I think you have demonstrated that when you train yourself and you get into the team and you provide the service, like you're saying, active part of the team, you save life. And I think this is actually showing, and I want to congratulate you. But I'm quite curious how you were able to break some of these barriers, and get into the team to really show that you really have a key role. And it's very true. All the things you're talking about, very, very true. The pharmacist involvement makes a difference. So how were you able to break through? That's my curiosity. Thank you.
All right,
Can
thank
I-
you, sir, for that question. Yes, Ma, you can take it.
Okay, yeah, just like we have talked about, when you specialize and they're able to see that you're adding value to what is happening, then they're able to invite you to whatever they're doing. Or when you now say you're coming in for what ones and all that, they're not trying to stop you from coming, because they see that when it comes, either you're telling them what is beneficial to them. I think it's the only unit that one person feels that can learn to go up. They always need to get cues, one person or the other, so they are not doing the wrong thing. It's one thing. I've worked in various units in the hospital, where I see that doctors are not willing to work with other professionals. But here, I think every information they get is very important to them, and that information can go to any member of the team. So I think they're willing to let us come in so that we
Guy,
can
not
to
for the
the
office, so where will you go, guy?
Yeah, let's put something out like don't view.
Can we mute our mic, please, if we're not speaking, so that we can hear who is speaking? Thank you.
No, yeah, just like your status, bro.
finish talking.
No,
I wasn't heard. Hello.
You can continue, Ma.
Now finish talking.
Oh, okay. Okay. So, in the absence of any other question,
Okay, so can I
do we have
hello, can I add
contributions?
to what? Okay, I wanted to add to what pharmacist Babalola did mention, how she was able to break through. I think we have our national chairman, Dr. Moinua, for I think my own challenge in my facility, because I work in Federal Medical Center in Agoa. We had that challenge, actually, we did, to the point that the physicians didn't see the need and they kept feeling, what do you bring to the table and all that. And sometime our former MD actually was sending some pharmacists to UNTH, University of Nigeria Teaching Hospital, where our national chairman works, because they were doing open heart surgery and all that. And so facilities were going there to learn. So when this new MD came on board, he wanted to start afresh. We did not. We kept showing. Initially, he felt there was no need. But when they saw the need, when they saw our contribution, our participation, our what we do, our goal is not to interfere with any medical management, but to contribute our expertise in optimizing medication therapy. We want to improve patient safety and support better clinical outcome for these critically ill patients. And they saw the way we communicate, and they saw that the teamwork improved within the healthcare system. And then they begin to feel that there was no need to, stop us. But the challenge we are having right now, just as we didn't mention, challenge in ICU is staff are not much. So not many people are interested in it. And we have so very few persons that are really involved. So we are really working to bring in younger ones to join us and emphasize collaboration, professional relationship. And then that was when they begin to see the pharmacist value. So some facilities, I understand, are still, because some persons, when we talk, they are still like their facilities don't allow them and all that. I think we should not give up. If you are in that kind of facility, we should continue pushing, and make friends with the management. That's what I see. And before you know it, your relevance will become important. Although this particular MD has not resumed what the former MD was doing, sending some pharmacists to UNTH, but recently even talked about it through the HCS. So, and our residency program we had recently, when we were doing our specialty in the last 6 months, we now wrote exam in November, made me visible in the ICU, really, really visible. And the nurses are always, always, always welcoming. Those ones cannot even do without you. Before they dispense anything, they want to call you, and so I started with the nurses, started making friends with them. And from the nurses, I entered the physicians. So that's it. So that's how I started from my side. Thank you.
Thank you. Thank you very much. And if I may add, maybe now let me introduce myself properly. I am a clinical pharmacologist and professor of pharmacy practice. I'm the vice president of the Ghana College of Pharmacy. So this is really great. And I would want to encourage that we also collect data. I think it's very important that we get some of the residents, the people who are going through West Africa College of Pharmacies, residents, to do projects in some of these areas and collect data, see the impact of interdisciplinary practice, and then the role of the pharmacists and all of that. Some publications here would also be able to help to showcase to the other areas of practice, so that all of these animosities and infighting, they realize that the most important thing is the patient life, patient safety. And I congratulate you for a great work that you are doing. Thank you.
Thank you, sir. Thank you, Ma. Thank you from Baba. Thank you from Timothy. In the absence of any other question or contribution, I would like to, on behalf of the organizers, I would like to sincerely thank both our presenters for their excellent contributions. And I also like to thank all the participants for their engagement. We appreciate your time because it's quite late, and also the inputs. Special thanks to SIPAN National and our Education Committee. Today's session has reinforced the message behind our topic. Indeed, when seconds count, teamwork, expertise, and dedication can save lives. We
Sorry,
appreciate
can I talk,
everyone.
please? Can I speak to you, close?
Say that again, ma.
Let's
I want to speak before you close.
Okay.
She's not
Yeah,
closing. She's still going to be and for both of times.
All right, go ahead. Sorry.
do you have something to say, ma? Because ma, do you want to say something? I can
Of
hold
course,
off
I
on
want to
this.
say
Yes, please, you
something.
can go ahead,
But
ma.
I thought
Sorry.
you were rounding off. So that's
Yes,
why.
this is towards my closing remark, actually. So if you have something to say, I can pause and then
Okay.
just let you.
Thank you so much. I want to thank the organizers of this critical care uh, presentation tonight. I'm Dr. Nwafọ Mori, the National Chairman of CPAN, and the one best Oscar one of critical care pharmacy in CPAN. So I really want to congratulate pharmacist Babalola and Dr. Timothy for organizing this great work this night. Thank you so much. I'm really proud of both of you. Actually, critical care is a new specialty in clinical pharmacy. The awareness is still very, very low here in Nigeria based on research which I did. And I can tell that we have a long way to go. But at least we've started. For us in my center, that's UNTH, is really gained ground. We are visible, we are not trading other pharmacies because our impact has been felt. In my master's work, the work was the impact of assessment of drug therapy problem, intensive care unit of a tertiary hospital. Within 1 year was a prospective study. We identified 729 drug therapy problems. Can you imagine if there was no pharmacist in that unit at that point? So we have a great work to do in intensive care unit. So I encourage other pharmacists to key into our specialty because we just have few pharmacists who are interested in this specialty. Even in the Watercamp Postgraduate College, you can see just 2, 3, 5 and a class. So I encourage our audience tonight. If you're not a member of CPAN, please join CPAN and also join us in our platform for critical care pharmacy specialty. And also enroll in WATCP for your specialty, certification. I would just want to add that for us, we must have to start with pharmacist ward round first. Do your ward round first, get to know your patients, and yourself with information, then you now join the multidisciplinary ward round so that you can have something to contribute during the round. So it's very important that pharmacists start their round first. Come to work early enough, enter the ICU, know your patient, get the information, then join the multidisciplinary round. Then in terms of anticoagulation, which we are now, we have started the anticoagulation stewardship. When they were talking, they said about anticoagulation optimization for stroke patients. Yes, but basically, almost all the patients in ICU are given anticoagulation within 48 hours of admission. So it's very, very important that we pharmacists key into knowing more about anticoagulation stewardship to prevent DT and other complications. So on this note, I want to thank everyone, especially my NEC members who are here, Dr. Issa, Dr. Tini, I can see from Juan Taroland, my dear Assistant Secretary, and Dr. Meg Obonu. Thank you so much for joining us. We've already started again after just few weeks break. So every Friday, CPAN meeting, stay on. Please try to join us. Thank you and have a pleasant night's rest.
Mama, I didn't realize you were even the one talking. Thank you for taking out time to join us, ma. Linda.
Thank you so much, my SIPA National Chairman. We appreciate you. Linda, our moderator.
I thank everyone to join. The attendance is quite good and it held on to the very end. We want to appreciate you all for coming on this call and staying till the very end. Hoping that join us on other episodes when we come. It's like the SPAN chairman has said. Thank you very much and have a very good night. Bye-bye.